So obviously today we're going to talk about insomnia. This is a really, really common issue with many of the population, so much so that a lot of your patients aren't even going to bring it up to you because it's so normalized. So I think this is a pretty important primary care topic, and it can go really, really deep. But what I've tried to do for this presentation, especially since we're virtual, is I really revamped my old slideshow and things like that, and cut out a lot of the fluff, a lot of the stats. And I want to focus a lot more on putting tools in your hand so that practically you can apply some skills to your patients. So the interesting thing about treating insomnia is it is somewhere in between a symptom and a disease itself. And so many things about this is like a vicious cycle. The insomnia causes worse mental health. So that mental health causes insomnia, and we go round and round, and kind of the snake eats its own tail. That is because so many things in society, in culture, in medication management cause insomnia as a problem, and vice versa. And so keep that in mind throughout the presentation. This is also a very functional disease. So much so that in a couple slides, I'll tell you a little bit about that. But there are four main types of insomnia. One is about initiation problems, so people that can't go to sleep very quickly. We've got maintenance problems, so people that can't stay asleep for long periods of time. People that wake up unrested, so maybe we're not going through all the sleep stages and not getting enough rest. And then people that wake up really, really early and can't go back to sleep. The downside is there is a great deal of overlap with this. We're not lucky enough to be able to say you can only have one. There's a lot of overlapping, and you could have all four of these problems, in fact. We'll go ahead and count sheep as we go through here. And maybe I'll actually put a few of you to sleep. So like I was saying before, this is somewhere in between a symptom and a disease, and I want you to keep in mind this is a very functional deficit disease. And so these are just kind of highlighting some of the things here, but it is more than just being uncomfortable or unrested. There are real problems associated with insomnia that really need to be treated. And I am positive that all of us that went through grad school or med school have had nights where we basically don't sleep at all and kind of pull those all-nighters, and it's just kind of expected in our culture to sometimes do that. And so it might be tempting for us to kind of just tell our patients, grit your teeth and bear through it, like you'll make it through the day. And it's true, they do make it through the day, but there are more than just those uncomfortable parts. There's a lot of other things, and some of the bigger issue things, we can have absenteeism, people calling in sick because they didn't sleep. We have a lot more healthcare utilization. There have been tons of research on performance at work, and people that have insomnia get far fewer promotions than somebody that's well rested, a lot more auto accidents, and people tend to gain weight. So these are all things that start. Not only is it that snake that eats its own tail in this vicious cycle, now we also start introducing secondary problems to the equation. And it becomes a bigger and bigger snowball effect of what this is causing in the world of healthcare. So if you don't mind, unmic yourself, and if you can answer this question, but tell me, in the primary care office, how often are you treating this, and what do you think is causing all the issues with insomnia?
I think I probably talk about it at least on a weekly basis. And a lot of it, I think, is poor sleep hygiene, having a TV in the room and those sorts of things.
Yeah. So that behavioral component to it either is unmet, or they're doing some behaviors that might actually cause some insomnia. Yeah, I think to hear that you're doing it every week is not surprising to me at all. Sleep hygiene stuff. Any other things you guys are noticing of what causes some insomnia in your patients?
Dr. Millam's in the room with me too, and she mentioned anxiety.
Yeah. Yeah. So mental health and insomnia go hand in hand.
Yeah.
And kind of challenging with mental health disorders is we well know that with mental health, you can either have too much sleep or not enough sleep. And so sleep dysregulation is a big part of basically any mental health issue. And by the way, speaking of unmuting your mic, feel free to unmute at any time and ask questions and stop me. I'm happy to pause. But here are some of the few of what is a nearly infinite list of causes of insomnia. You guys mentioned the behavioral components. So a lot of those sleep hygiene habits aren't being made. A lot of substance use. This includes caffeine and nicotine as stimulants, as well as alcohol as poor sleep aids, as well as a whole host of other substances that we might use. Changes in schedule, third shift. In fact, I just got done talking to a warm handoff that Dr. Shanady and I had. He works second shift, and so he sleeps like right now is when he would be asleep. And so he had mentioned that it's really difficult to manage things because he has to have a doctor's appointment in the middle of it when he would be sleeping. A lot of medical things going on too. Specifically, medications can be a big issue for this. Some medications may cause drowsiness, but a lot of medications are also going to keep you up. We think about like ADHD medications, psychostimulants, and things like that. They're going to be really problematic for that. We also see a lot of patients in this office that have a wide variety of reasons. They might have pain. Pain is something that can really keep you up. One of the best strategies for pain management is distraction. But one of the best things we do for sleep is try not to be distracted. We want to be really mindful about our sleep. And so when we finally turn off that distraction in our brain may be flooded with pain signals, and that can be a really, really challenging thing. And there is a whole host of, there are many, many causes for this, but these are a few that we probably realistically see in the office pretty commonly. So a typical night of sleep for people in this audience, if we were to get 7 to 9 hours of sleep per night, that would be really, really excellent. That's really what our body needs. And you'll see, I'm not going to list off every age range, but from infancy all the way up until adulthood, you need, very young people need a lot of sleep. If you take a look, babies are sleeping more than half the day. Whereas as you get to an adult, we start rounding down into about 8 hours on average is what most people need for sleep. If I were to poll the audience here, I would be very doubtful that 100% of us are completing 7 to 9 hours of sleep every night. But that would be one of the best things we can do for our wellness, our mental health, our energy levels, our preparedness for work, and so on and so forth. There is a myth, or there was like research in the past, but it has been debunked, that as we get older into an older adult status, we need less and less sleep so that we're getting 5 or 6 hours of sleep. That has been proven not to be true. And the reason we believe that was because the sleep that you get when you're younger is going to dictate the sleep you get as you get older. And so if you were one of those high school students that we see in the office here that plays video games all night, every night over the summer and has no regulation or routine, that is going to come back to bite them when they're an adult as well. And so just like anything in primary care, an ounce of prevention is worth a pound of cure. And so when you're talking to your peds patients, when you're talking to parents, that is something that you should really, really stress. In fact, I come from a pediatric psychology program, and what we discussed as the frontline treatment method for almost any mental health was sleep first. Tackle the sleep first, then you can start getting into the CBT, then you can start getting into the interpersonal therapy, you can start asking the big ticket items. But if you have somebody coming in to do some behavioral management without any sleep, they're not going to be able to be in tune with that. They're not going to be able to catch up on their exercise because they're going to be too tired. They're not going to be able to do the CBT because their cognitive ability is going to be too slow. And so we're going to really want to tackle sleep, one, from a preventative stance, but two, early in the treatment of many, many diseases. So how we evaluate this is I would hope a very thorough screening at various time points. So if you have somebody that has problems, obviously you're going to want to do a really, really thorough exam. But as you get to know a patient, as you meet a patient, this is such a common illness that I would expect at some point in your history and systems gathering, in your note review, or in your intake interview with the patient, that you should at least be doing some base sleep questions. And so if you take a look over here, this highlighted one, the Epworth sleepiness scale, that has just a few questions you can ask. It would take less than 10 or 15 seconds to ask just I think there's like 3 or 4 questions. But you can ask just some general questions, just get a quick snapshot. And if they are having problems, you can kind of refer to this history list here and start asking a little bit more deeper questions. And if you do find that there's a problem, one thing that I would advise is to do a sleep diary. And I try to make it convenient for you. If you look on New Innovations and pull up this PowerPoint, you can click these links. I chose well-vetted links that are evidence-based, as well as a really pretty picture and easy to print off and give to a patient. And so I'm not going to click those links today just for fear that I'll screw up the visual portion of the presentation right now. But do take a look at those, and those are definitely things to hand out to your patients. Sleep diary is really, really easy. There's going to be a lot of questions that you answer in the morning as you wake up, and then there's going to be a set of questions you answer as you go to bed, or right before you go to bed. I don't want our patients doing a sleep diary. I don't want them waking up in the middle of the night with their insomnia and then filling out, check boxes that, oh, I woke up 3 times through the night. That's actually going to perpetuate the problem. But those would be 2 things that I would highly advise you guys do. If they already have some form of sleep treatments, such as like a CPAP, if they grind their teeth and they've got some kind of like implant from a dentist or something like that, you want to evaluate, make sure they're actually doing those treatments. And then if the cause still eludes you at that point, I would go ahead and get a sleep study going, and you can find out a lot from those. So Dr. Steiner brought up earlier about sleep hygiene. So this is probably the frontline treatment, and I would assume what you guys get taught in med school about the behavioral components of sleep is probably related to sleep hygiene. So let me take another pause moment here, and I'll let you guys unmute your mic and tell me, what are you already telling your patients about sleep hygiene?
I'm telling them, don't have a TV in your bedroom.
Yeah, that's the biggest ticket item probably on there. That's the hardest thing on the item, on the list for a lot of my patients, but most definitely. What else are you guys telling them?
Talking to them about medications and caffeine, and I talked to them about the half-life of caffeine, which surprises a lot of people, how long it is. And I really recommend to them to not have any caffeine after noon, if they can help it. And I actually have a sleep hygiene handout that I made. I created it, I think, when I was a resident. I've updated it a few times, and I give that out to every patient.
Perfect. Yeah, this is a technique that's very easy to disseminate. And so if you have a handout, this is one that will be very easily understood from our patients too. It looks like somebody got a chat here. I'm going to be unable to pull that up without stopping the slide here. But if somebody had
said bye-bye 3 p.m. coffee.
Okay. 3 p.m. So these days, I am going to talk about caffeine, and these days I'm kind of living the life of do as I say, not as I do kind of thing. But people are often very surprised about the half-life of caffeine and how much caffeine is in various drinks as well. So anybody else, what else do you like to put on your sleep hygiene discussion?
Dr. Milam, I'm sorry I mispronounced her last name last time. She mentions not having a cell phone by the
Ooh, I love it. Yeah, that's one of the things I talk very deeply about with my patients. A cell phone is a double whammy because, one, it is a temptation to have a screen on before bed and during like your wake up time. And then secondly, we often, these days, we use our cell phone for like a clock or an alarm clock. And there is really no point in having the clock when it comes to insomnia, and I'll talk more about that later. It sounds like you guys know sleep hygiene pretty well, and so I'm going to kind of highlight over these. Exercise is going, basically anytime I'm doing a lecture, exercise is the key. Exercise always for any issue. But exercise specifically, we should be doing it no less than 4 to 6 hours before bed. You absolutely don't want to hop on a treadmill right before you go to bed. That's like the last thing you'd want to do for your sleep. So what we really prioritize, in fact, if we look at the sleep hygiene pretty deeply, you'd want to prioritize that pretty early in the morning. But if you can get it 4 hours before bed, that's still gonna, you're gonna be able to ramp down from that. Kristen's already mentioned turning off the TV. That's a big ticket item. Patients really dislike hearing that. And for a lot of reasons. One, people like to be entertained. And then two, sometimes people have like ruminating thoughts and anxiety as they go to bed, and the TV can help drown that out. But I've got better options for that. You know, you can use your phone to do like a white noise, or a thunderstorm sound, or things like that as well that aren't going to have the screen on. Routine is a hugely important part of this. You always want to go to bed at the same time, and you always want to wake up at the same time. And if any of you guys are on night shift right now, I know that's like maddening to hear that. And you'll realize how that wreaks havoc on you, after the week of night float, and how you're trying to get back into the routine. So when you notice a patient doesn't really have a routine, or if they have like varying shift work stuff, that's going to be really, really challenging for sleep hygiene. Relaxing bath, like a warm bath or a warm shower, can be very helpful. I would advise not to do that right before bed, because we don't want you like getting hot or like sweaty, especially right before bed. That could be pretty uncomfortable to go to sleep. But if you do it an hour or two before bed, that can be really, really helpful. We've talked about sleep diaries. And then obviously you want your room to be a very comfortable space. If you haven't washed your sheets for months on end, it's not going to be a very comfortable place to lay. If, you've got bright lights on and things like that and noises in there, it's not going to be very comfortable. So, make it your kingdom, and, clean up that place so it can be comfortable. Some of the things to avoid, and these are, when you tell somebody to do something, that's usually a lot easier than telling them not to do something. And so some of the things we tell them not to do, though, are avoiding naps. Naps can be kind of like that cyclical pattern. Over and over will perpetuate the problem by taking a nap. Then we're more rested, and we don't want to go to sleep at night. And so if you do need a nap in the day, I recommend it to be 15 minutes or less. We don't want you to go through a full sleep cycle in a nap. Otherwise, you're really going to stunt your sleep in the evening. And so avoiding naps is very challenging, and people hate to hear that you can only have a 15-minute nap. People wouldn't even consider that a nap, truthfully, and that's why we recommend it that way. Avoid stimulating activities before bed. This is video games, TV. If you're reading a really, really engaging book even, you might want to pare back on that before bed. If you aren't falling asleep, I want you to get out of bed after about 20 minutes. The last thing I want you to do is reinforce, like kind of classically condition yourself to be in bed and be awake. And so if you're just like tossing and turning for 20 or 30 minutes in bed, I want you to get up and go out and do something really boring and unstimulating. This will be the time to go clean your bathroom, or read a really boring book, or something like that. And so once you start feeling sleepy again, then go hop back in bed. And if you toss and turn again, get back out of bed. Repeat that as often as necessary. That's going to be to help break that cycle of ruminating on sleep. And then in terms of what we put in our body, obviously there are a myriad of drugs that people put in their body, both recreationally and medically. But some of the things that are most common that we need to talk to our patients about is alcohol. A lot of people use this as a sleep aid. It is a really bad sleep aid. People will report they will go to sleep a little bit quicker, but they, one, wake up in the middle of the night as we start to withdraw from that alcohol. And then two, the quality of sleep that they get while they're intoxicated is very poor. And so alcohol, you should cut out alcohol about 4 hours before bed. And so this would essentially mean if you're having a glass of wine with dinner, that should be the end of that. And nicotine, we have a lot of smokers in our clinic. and nicotine is a stimulant in itself. Nicotine should be cut out about 2 hours before bed. That's one that patients really have a lot of difficulty with. It's not as common these days, but I used to have patients all the time that would smoke while in bed, and that was like, one, kind of scary because you might burn your house down, but two, really stimulating and it'd be really bad for your sleep. Heavy meals, in fact. So if you're gonna have a really big meal with your family, something like that, have that at 6 o'clock if you're gonna go to bed at 10 o'clock, because it'll take about 3 hours or so before you start feeling comfortable enough to go to sleep. But obviously what I would recommend is a more healthy portion meal anyway. And so heavy meals should be limited. And then caffeine, I would cut this out just like Dr. Witt said. I would say noon is probably about the time I would have you cut it out. I have, over time, I've increased my caffeine usage, but my last cup is usually by 9:30 a.m., just so I can be pretty assured that it's mostly out of my system. But here is a kind of a chart to kind of display this. So I read some updated information, and depending on who you are and how you metabolize it, it can be the half-life can be anywhere from 6 to 9 hours to metabolize the half-life of caffeine. And so if you're drinking Dr. Witt was very kind to us a couple weeks ago, and we were in a really big meeting for a really long time, and he offered to get the handful of us that were in that meeting to go get coffees. As much as that would have stimulated me into that meeting and kept me like working, it was probably 4 or 5 o'clock, and I would have absolutely not slept a minute that night. And so I still took him up on the offer, so thank you, Justin. But I just got a decaf at that point. But if you take a look at, I believe you got it from Starbucks. If you take a look at Starbucks' website to see how much caffeine is in there, it's more than double like a pot coffee caffeine usage. In fact, the way Starbucks makes their coffee is they actually put more caffeine in than what the coffee beans naturally have. And so if you're going to one of those types of coffee shops, then you're likely getting a massive amount of caffeine. So I think the small, whatever it's called at Starbucks, was something like 250 milligrams of caffeine. So this is something to tell our patients, but also to remind ourselves, if you are a caffeine user, make sure you cut it out probably by about noon. Okay, let's move on from the background stuff. Let's move on from sleep hygiene, and let's talk about things that you may or may not have talked about. And this is mostly the meat on the bone stuff here, the stuff that you can take to your actual clinical practice. The first technique is called stimulus control. And what this is basically some classical conditioning of your bedroom. So we want the bedroom to be used for sleep only. This is something that is difficult for, especially like families and stuff like that. I've heard like people say, well, I just can't get a moment's peace in the house. So like I'll spread my bills out all over my bed and, work on my payments or, do my homework on my bed because I live in a shared space with my roommates, that kind of thing. I would really try to avoid that. The last thing we want you to associate with your bed is like stress or anything like that. And so use your bedroom for sleep only if at all possible. Go to bed when you're tired and sleepy. So don't set yourself up for failure. We want to keep you within a range of a routine. But if your normal bedtime's 10 o'clock and you're like wired at that time, wait the extra 20 or 30 minutes until you start feeling a little bit tired to go to bed. Hide the clock. So I believe Dr. Milam had brought this up earlier, but when you look at a clock, the only thing that you do in the night is say, if I fell asleep right now, I would get 6 hours sleep. And that guarantees you're not going to go to sleep for the next hour. And then you look at the clock and say, well, if I went to sleep now, I'd get 5 hours sleep. And you just keep ruminating on that until you basically just get no sleep at all. And so what I tell my patients is completely get rid of the clock. If you use your phone for an alarm, set the alarm. You can be guaranteed that will go off. Turn that upside down and don't ever look at that. And then I used to have this like really bright digital clock too. That's just another form of screen time that we don't want. We don't want to have a really bright clock in our face in the middle of the night anyway. Light therapy upon waking is going to be really helpful. I didn't mention this earlier, but For a healthy adult, the typical go to sleep time should be less than 30 minutes, and the typical waking time should be less than 30 minutes. And so you should be at your complete sleep within 30 minutes, and you should be at your most awake within 30 minutes. And light therapy can be really helpful for that waking cycle. And so it really, you can get like UV lights and things like that, but that really doesn't matter as much as having a slow and steady kind of rising with a light. So if you think about Indiana in the wintertime, it's dark when I wake up and it's dark when I go to bed, and I don't have a window in my office. So there are sometimes I don't even see the sun ever. And so making sure that you have a way to be exposed to light can be really, really helpful in waking in the morning. The best way to do that would be gradual increase in light. And so you can actually buy light boxes off like Amazon or anything like that, that is specifically designed to go off with your alarm clock and kind of slowly wake you up with the light as if you were waking up with the sun. And then avoid bright lights at nighttime. So the exact opposite of that. So if you're doing a lot of screen time and stuff like that, that would be something to really cut out. One thing I've done for almost every app that I can get on my phone, I've put the nighttime mode on for all hours of the day. One, it just helps the strain on my eyes, but it does help alleviate a little bit of that kind of bright light that we get from screen time. So if you can put on night mode on apps and ask your patients to do that, but that doesn't completely resolve the problem. It just kind of puts a Band-Aid over it. Best would be not to look at screens at all. Paradoxical intention. So this is a really cool technique that patients are always pretty inquisitive about, and they don't really understand how it's going to work, but it does. And so this is a really good technique for patients that worry about sleeping. And so if you go to bed and worry that you're not going to go to sleep, what I would ask that patient to do is actually go to bed and do nothing but think about, I have to stay up tonight. I have to stay up tonight. I can't go to sleep. Force myself to stay up and have them kind of repeat that mantra in the head. And it's a really weird way at getting at a rebalancing and allowing the mind to break the cycle of worry that keeps people awake at night. It's not thinking that keeps you up, but it's anxiety that keeps us up. And so if we're forcing our patients to do something that doesn't make them anxious, like staying awake, then we can break that cycle and help them get into a better routine. It's really simple. It works really well. We just have to get buy-in from the patient to do that. I think patients will have some initial nervousness about that they might actually lose sleep because of it. Sleep restriction. This is one of the best techniques, but also one of the toughest sells that you're going to give. And so use this for patients that have tried all the other stuff. Patients already hate sleep hygiene at times, and this is far beyond that. And so if patients have tried the sleep hygiene thing, if they've tried the paradoxical intervention, if they've tried stimulus control and relaxation techniques, this would be probably what I put on maybe like the last resort behavioral treatment. What I'd have you do is estimate the time that's being slept each night. And by the way, patients that have insomnia greatly underreport how much they're actually sleeping. So if they actually sleep 6 hours, they're reporting 4 hours. If they are actually sleeping 4 hours, they may report 2 or 3 hours. And so that's not to say that they're lying or anything like that, but it just kind of goes to show how frustrating and how intimidating this disease can be on somebody's life, that it just gets so greatly emphasized. But you have the patient estimate how much time they sleep per night. So if the patient says, I sleep 5 hours a night, that is the amount of time you would allow them to even be in bed. So they go to bed at 10 and they would rise at 3 a.m. It sounds ludicrous, and your patients are going to tell you that, very much so. But what this does is it forces your patient to get into a habit, because those first nights, they're not going to get 5 hours of sleep in that night. They're going to get 2 or 3 hours of sleep in that night. And then by the next night, they're going to be physically and mentally exhausted. And then they'll go to bed that night and maybe get 4 hours sleep. And so over time, their body will get more efficient with the sleep-wake cycle. about the time your patient gets to about 85% sleep efficiency, then you'd add an hour or two to that regimen. So if we're talking about 5 hours, and they get up to 4.5 or 5 hours, excuse me, if they get up to 4 or 4.5 hours of sleep, I'd move that up to 6 hours in bed, and so on and so forth until we get to that 7-9 range again. It is a very difficult technique to do. It is a very tough sell to do it, but it is highly successful as well. And so if your patients have tried everything and they're willing to try something even more drastic, this is a great technique.
I'm sorry, can you go back? I'm
Yeah.
confused by the sleep efficiency, what that means.
Right. Okay. So if you're asking your patient, I'm going to use a really round number just so I can do the math. But so if you're asking your patient to be in bed for 5 hours a night, you would want them to get 4.25, 4 hours and 15 minutes worth of sleep before you would add more time to being in bed. So if they are sleeping in that 5-hour span that you're allowing them to be in bed, at 85 of that is they're conked out, that's the time to move it up to 6 hours. Vasi, is that understandable? I may not be explaining it very well.
Yeah, that's more clear.
Okay.
Thanks.
Perfect. Yeah. Relaxation therapies, these are opposite of what I was just saying. These are the bread and butters. These are the easy ones. If they're not doing this, if they're not going to try these, they're not going to try anything. And so these are things that are easy to do and make you feel good immediately. And so these are really no-brainers. Is everyone here familiar with progressive muscle relaxation, PMR? If not, raise your hand and I'll explain deeper about what that is. And while you do that, I'll kind of explain a few of these. So progressive muscle relaxation and let's see what else we got here. Biofeedback and diaphragmatic breathing. Those are all physically relaxing things. So that can be helpful for people that go to bed with pain, people that have like physical tension. You know, like sometimes I'll go to bed and my shoulders are like super tight if I've been stressed out all day. These are really great techniques to help physically relax people. And I did see one hand raise, so I'll explain a little bit about PMR. So what progressive muscle relaxation is a technique where you progressively tense your muscles and then relax your muscles. And the focus is on the difference between tension all the way into deep relaxation and kind of reminding yourself of muscle memory and times when you're very, very relaxed. And it's a great way to kind of go from the top of your head down to your feet and just check in with your body to say, where am I holding tension? Sometimes people don't even realize they've been holding tension all day because it's so normal to them. And then when they relax that, they go, oh my God, I feel so deeply relaxed now. And it can help people fall asleep. I am a practice what I preach kind of guy in a lot of ways. And I do progressive muscle relaxation. I'll do mindful meditation and diaphragmatic breathing when I lay in bed at night, because it's just a good way to help drift off. I don't particularly have insomnia these days, but I do that anyway, and it's just a good practice to be in. In fact, when I was getting trained on progressive muscle relaxation, my professor told me never do it with your patient, just explain it in the background, because sometimes you'll get like kind of lackadaisical at the end of your session because you will become a little more relaxed than you want to be in that session. It's a very easy thing to do, and your patients really love it. On the opposite end of that physical tension, we also have mental tension. And so mindful meditation, guided imagery, and I know nothing about self-hypnosis, but it is an evidence-based treatment. Those three are very good for the mental tensions that we build up in the day. And so with mindful meditation, we have people let their thoughts kind of pop into their head, non-judgmentally let them float away, and then try to have the absence of thinking. And I usually tell my patients to focus on their breathing and literally just think about inhale, exhale. I have other lectures where I'm going to go into each one of these other than hypnosis in much greater detail. But if you have any questions related to insomnia, ask me at the end and I'll go into more detail about it today, or you can come by my office and we can even go through like a role play of each one of them. But in the interest of time, I'll move on here. So everything I've talked about is very evidence-based. So there's tons in the behavioral health handbook, in the toolbox that we have, there's tons and tons of things we can do. What works best though is the thing that the patient will do. And so what you always want to ask is, realistically, are you going to do this homework? And so if you're asking them not to take any naps, you want to ask, realistically, are you going to do that? And if they say no, and in my anecdotal history, patients will tell you if it's not going to work for them. And so I wouldn't prescribe that then. I'd go into something different. If you tell your patient to turn the TV off and they say, that's just not going to happen, my husband or my wife won't do that, and I sleep in the same room with them, okay, cool, that's not going to work for them, so let's do something else. But if we can attack it at multiple fronts, that typically works best. And so without overwhelming a patient, I would give them multiple things in that first kind of initial trial of treatment. Chronic insomnia usually takes multiple attempts. It is a behavior that is learned over many, many weeks, months, years, even decades. It's going to take a little while to get rid of it as well. People that use behavioral therapy, so people that see one of my residents or something like that, sleep latency is reduced in 81% of the patients, and sleep maintenance is increased in 74% of patients. So if you come and see us, you are very likely that you will be successful in improving your sleep. I can't guarantee it'll be perfect sleep, but it will be improved. And that is, in the world of behavioral health, that is a staggeringly high number. And so that is a really good option, is to refer somebody to us. In primary care, obviously, when we integrate and we do a co-led session, if we do medication management and behavioral management at the same time, that is far and away the best, but it's still clinically significant if just the physician alone utilizes those CBT techniques that we just started outlining. The good news about all of the techniques, with maybe the exception of the sleep restriction technique, they are basically risk-free. If you ask somebody to turn the TV off in the night, there is no harm that is going to come to your patient. If you ask your patient not to take a nap in the day, there's no harm that is going to come to that patient. So it is basically risk-free. And on the end of the behavioral end for a physician, these are also very easy techniques to give. You don't need to know the ins and outs of the patient's psyche. You don't need to have a very interpersonal mix of therapy within the CBT. You can just give the technique and kind of walk away with that, and that is all the patient really needs to improve. And so this is one of the times I would say you should definitely understand and utilize these techniques yourself. We love to have the handoffs, but we would also love to teach you the techniques so that when you graduate here, you can be the behavioral counselor for someone with insomnia. This would be one of those times that it wouldn't be out of your scope at all. Things I couldn't cover. Oh, and this sheep, if you do you guys yourself a favor, I saw one sheep that was dabbing, and I thought, what a ridiculous thing that exists in this world. And so I Googled dabbing sheep. There are hundreds of them. I couldn't believe it. So do yourself a favor and Google sheep dabbing. You'll just see there's a whole new art form out there that I never knew existed. But there are a ton of things I couldn't cover here. So medications is a huge one, very huge, especially for a primary care doctor. Herbal supplements, over-the-counters. In fact, my fantastic doctor, Dr. Janegi, she had asked me about sleep, as you do as a primary care doctor, and I had said, oh yeah, I use, I forget the name of it, but this over-the-counter medication, I've been using it for 4 or 5 years, seems to be working well. And after she picked up her jaw from the floor and told me, don't do that, that's not good for you, we had a really great conversation about that, and I cut it out, and here I am, I'm still sleeping good, and so I'm very appreciative of that. But even as a psychologist that talks about insomnia constantly, there were things I was doing in my life that I didn't even recognize could have been like habit forming. So herbal supplements is a big thing, things like melatonin and Unisom and stuff like that. The jury is kind of still out on whether that's healthy or not. Parasomnia, so sleepwalking, night terrors, stuff like that. No time to talk about that today, but there's a whole world of that. Shift work. In fact, the DSM is exploring shift work for further diagnosis, because, if you think about like a police officer or a firefighter, that works like a first for a couple weeks, then a second for a couple weeks, and a third for a couple weeks. That's like an absolute terror on your sleep. And so keep that in mind for your patients. I didn't talk about sleep cycles or the neurobiological kind of components of sleep, but there's a big world there. But if you want to cover it, I left the link here. There is a 162-page manual for primary care doctors on insomnia. And so if you ever want to cure your own insomnia, I would recommend starting to read that, and you'll fall asleep very quickly. But I couldn't cover those things, but they are all listed within that manual for primary care physicians. And so please do check that out if you have a very specific question that I didn't get to. Okay, now I'm wrapping things up here. I would like to ask, if we are counting sheep and trying to go to sleep here, how many sheep were in the presentation? If you know the answer, go ahead and unmute. And if you know it, you can win your choice of, if you don't sleep very well, I got you guys some melatonin. And if you sleep too much, I got you a Red Bull. You can win one of the two. And if you don't want that, I actually got real prizes too. So holler it out, or you can put it in the chat, and I'll let you know after question and answer what the answer was. But we'll see if anybody was counting sheep during my lecture. Usually that's a bad thing. Here are my references, and I usually don't highlight a lot, but really, truly, this clinical guide for primary care physicians is very good. I would recommend having the link saved on your computer. Okay, Q&A time. Any questions about insomnia that I can perhaps help with? And I will check the chat too and see if we've got any questions there. Oh, we got lots of answers. I love it. Okay. Sorry, Gin Bunch. Bye-bye 3 p.m. coffee. That is right.
I will just add in real quick on the medication front, since Dr. Rainey did not cover that. There is a really good review article that is still current in the American Family Physician. It was from July 2017. It is written by a fellow ABFM test item writer. And anyway, I think it's a good article. It talks about several of the medications. And if you're not familiar, it does talk about low-dose doxepin, which is an old drug that's been around forever, used for a while to treat depression and anxiety, but now can be used in low doses for treating sleep. And that's been a helpful addition to my formulary. When this article came out, that was the first I'd heard of using that.
Yeah, great. Thank you, Dr. Webb. I have a question from Kimmy. What do you do when your landlord put a security light right outside your bedroom window? Asking for a friend. Tell your friends to buy a BB gun, and I'll take care of that light pretty quick. And over time, they'll just stop replacing the light. Oh, Dr. Townsley left a real one. Actually, blackout curtains would be a very good piece of advice. Have I tried a lavender eye mask? Kristen, you will be pleased to hear I have actually tried that. I did not particularly like it, but it is a great way to reduce light intake. So if you've got that kind of couple that I was talking about earlier, where the husband likes the TV on, but the wife doesn't, that'd be a great thing to kind of invest in. Looks like Dr. Milam has a comment.
So I actually prescribed doxepin for the first time last week, and the low dose is like 3 to 6 milligrams for insomnia, but the capsules and the tablets have very different costs, I have discovered. So the tablets are extremely expensive. So you can only get the 3 or 6 milligram in tablet form, and it's hundreds of dollars. Whereas the capsule form is 10 milligrams, and it is much, much, much more affordable. So just an FYI, I did not realize that until trying to prescribe it.
Yeah, see, yeah, you're exactly right, Dr. Milam. That's a great point. I prescribe the 10 milligram capsules. That is off-label, so I do tell my patients this is the same ingredient that's in the drug that's marketed for insomnia, but I'm giving you the option of using the older generic one. Just realize it's 10 milligrams instead of 3 or 6. And I tell them, look, a couple extra milligrams is not a big deal. We used to use this stuff in 150 to 200 milligrams per day for treating depression. So yeah, very good point.
Yeah, great questions.